All right, it's 7 o'clock here in Abu Dhabi. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone, and welcome to another exciting installment of the multimodality rounds brought to you by the Imaging Working Group of Emirates Cardiac Society. As always, we try to bring together the best of local and regional experts to dive into practical applications of advanced cardiac imaging across various disease states. Tonight's installment is going to be as insightful and as informative as always. Before I start, let me introduce myself. My name is Firas Al-Badareen. I'm a multimodality imager in Cleveland Clinic, Abu Dhabi, and I am the head of the Imaging Working Group of Emirates Cardiac Society. I'm absolutely thrilled to chair this session tonight with my wonderful colleague, Dr. Jack Ricard, who's going to introduce himself. Jack?
Thank you so much, Firas. I'm Jack Ricard. I'm the section division chief here at Cleveland Clinic Abu Dhabi of cardiology. I'm a cardiac electrophysiologist who trained at Cleveland Clinic in Cleveland. I've been in the Emirates for now 4 months and can't wait. We've got a really interesting couple of cases and great speakers tonight. So I think this is going to be a really engaging number of presentations where we kind of look to the crossroads of imaging and electrophysiology, and I think it's going to be really fantastic.
Thank you so much, Jack. I'm also looking forward to this session. I would like to start off first by extending sincere thanks to all of the speakers who volunteered their time and expertise despite their busy schedules to educate the audience on this very important topic. I would like also to thank our sponsor tonight, Saja, who sponsored this presentation and the session. And lastly, I would like to thank ICOM, who is works in the background to make this session come to you in the best possible shape. So without further ado, I'm just going to turn it over now to Jack, who's going to introduce the session and introduce the first speaker.
Okay, thank you so much, Firas. So our first speaker, Dr. Shafi, are you ready?
Yes.
Okay, our first speaker, Dr. Ferdinand Shafi, is a friend and colleague here at Cleveland Clinic, Abu Dhabi. He's an electrophysiologist. He's going to be talking to us about atrial fibrillation and give us some updates. Thanks, Ferdinand.
All right, well, good evening, everybody. So what we're going to do today in 15 to 20 minutes, we're going to talk about the role, the content overview of the management of atrial fibrillation. We know over the past several years that lots of advances have occurred in the field of management of atrial fibrillation. Briefly, we're going to go over this. I have no disclosures. What we're going to talk about today during this presentation, we'll talk briefly about natural history and progression of atrial fibrillation. In terms of management, we'll start with risk factor modification and then antiarrhythmic medication management. And then we talk about catheter ablation for the management of atrial fibrillation. We'll a little focus on pulse field ablation, which is a new modality that we are using now for the management of atrial fibrillation. We know that atrial fibrillation is a progressive disease. It starts up with a very small kind of short period of time of patient being in atrial fibrillation with a long gap in between. And then patient has another episode several months later or maybe a year later. And these episodes continue the same way in fashion. Finally, at some point, as you see it happening closer together, patient says, I used to have it once a year, now I'm having it once every 3 months or so. And then there's maybe a gap a little bit, but then more episodes happens. But at some point, you see another progression occurs, that patient goes into atrial fibrillation for a longer period of time. Instead of 20 minutes, now it's probably 6 hours or so. And then there's a gap and the same thing happens, and then progresses for a longer period of time. Patient goes into atrial fibrillation and lasts maybe for days or a week. If it passes beyond a week, we call it persistent atrial fibrillation. At this point, often patient cannot come out of atrial fibrillation on his own and sometimes has to come to the hospital to get cardioverted. So patient loses the ability to self-convert. And if it progresses further, and then there's no dilated left atrium and there's no option for the management of atrial fibrillation, at that point we call it permanent atrial fibrillation. In terms of the reason for atrial fibrillation, initially is a trigger, usually pulmonary veins or focus in the heart that's causing the atrial fibrillation. And as the time goes on, and AFib duration becomes longer, the trigger actually influence becomes less, and then there will be a substrate change in the heart. And now you have to deal with not only the trigger, but also a substrate change that's occurred inside the heart. Obviously, the management of atrial fibrillation at this stage is harder than at the beginning. We'll talk about that in a little bit more detail. If you look at it here, the risk factors, for instance, hypertension, obesity, sleep apnea, alcohol consumption, diabetes, and so on, it causes electrical remodeling, causes changes in calcium regulation that leads to delayed after depolarizations, changes ion channel, cause ion channel dysfunction, cause early after depolarization, hyperpolarization of the cells, decreased action potential duration, refractory period, and also conductive velocity. So all these things, changes that occurs, it leads to structural changes in the heart, which changes, the cells slowly change from normal cell to fibrotic cell. The fibrotic cell, as we know, it does not have a good conduction velocity. Now you have a perfect scenario for reentrant tachycardia. And if you have a lot of fibrosis in the atrium, you have lots of areas of reentrant tachycardia, and that's what happens in atrial fibrillation, especially in persistent form. You have increased automaticity, the cells are not normal, and also you have endoepi asynchrony. And also after that, you have autonomic remodeling that occurs, cause early after depolarization, delayed after depolarization, and lots of other changes. All these things leads to focal ectopic firing inside the heart, and also reentrant tachycardia, or be prone to reentry and atrial fibrillation. So we see the changes occurring over time from a focal to substrate changes over time with atrial fibrillation. Now, if we look at here, we see this is a relatively structurally normal heart, focus firing, causing the atrial fibrillation, easy to manage. With medication or with ablation, we isolate the veins, the rest of the heart is healthy, versus a dilated with lots of scar tissue in both sides, which identifies or shows substrate change. Now, in terms of management of atrial fibrillation, how to stop it, we have antiarrhythmic medication options, and we have also the option of using catheter ablations. But before we go to these two options, we're going to talk about risk factor modification, which studies over and over and over have shown that it is extremely important when we manage patients, but should not forget about risk factor modifications. Risk factors involve optimization of heart failure medications for people with low EF or diastolic dysfunction, exercise about 30 minutes a day, moderate to vigorous exercise, adequate blood pressure control, dietary changes to keep the hemoglobin A1C in diabetics less than 7, complete cessation of tobacco and alcohol, and also greater than 10% weight loss for people with BMI to bring it less than 27, and also, as we talked about drinkers, and also the sleep apnea management. Now, in terms of antiarrhythmic medications management, we have several antiarrhythmic medications which over the past 20 years almost, there have been no significant change. The same medications that were available at that time, they're also available at this time. So we did not really make a lot of progress. These are class 1 agents, which are sodium channel blockers, effective phase 0 of action potential. Among the ones that are listed here, for atrial fibrillation management, currently we use flecainide and propafenone most often. And then you have class 2, which is beta blockers we use very often, like propranolol, metoprolol, and so on. And then you have class 4 agents, calcium channel blockers, that affect the plateau phase or phase 2 of the action potential, especially the cardiac ones, verapamil and diltiazem. And then the most important ones are class 3 agents we use very often, amiodarone, sotalol, and dufetilide, which are all class 3 agents that affect the potassium channels and phase 3 of action potential. But no significant changes has been made to these medications, or new medications have not come out over the past 1 or 2 decades. But when we look at the medications, we realize that they are not that effective. If we look at this study that was published in New England Journal of Medicine by Andrade et al., we realize that the efficacy over a year period of time only is 32%. So that's really not, I mean, if you cardiovert and put patient on no medications, you're probably going to get a little bit less than that, but not big difference. And also when we look at the study FIRM trial, which was published in Circulation in 2002, we realized that the patients that when they were in sinus rhythm, they actually did better. But what offset the benefit of sinus rhythm was the antiarrhythmic medications that had increased mortality. So they basically canceled each other out, and we got the result that there was no change in cumulative mortality between rate control and rhythm control. To remember, in 2002, we did not really have ablation developed as much, or if it was at a very primitive stage. The first ablations happened at the end of 1990s, so it was not widespread use. We did not know how to do ablations. We did not have all the sophisticated catheters and technology that we have today. And if you look at the right side, the rhythm versus rate control, that actually was more towards the rate control because we managed patients purely with antiarrhythmics at that time. Now, if you look at the remodeling of the heart, if you look at the total strain or change in left atrial reserve function, the light blue being the ablation, we see that post-ablation it actually improves close to control. But with antiarrhythmics, the reserve volume goes down. So really, we're not doing a lot with help with the remodeling of the heart, especially also if you look at P-wave duration as a surrogate of the healthiness of the heart and how well the tissue is conducting electricity. We realize with ablation, the actually P-wave duration decreased to almost close to normal control, but with antiarrhythmics, the actually P-wave duration was close to 140 milliseconds. That again, some of these antiarrhythmics are sodium channel blockers that slows the conduction as well. So we're really not doing a lot of service in terms of remodeling when it comes to antiarrhythmic medications. Now, if you look at the recurrence of atrial fibrillation and the burden, when we compare ablation and antiarrhythmics, this is the study published in the New England Journal of Medicine 2021, comparing cryoablation to antiarrhythmics, we see the burden of atrial fibrillation post-ablation is much less compared to management with antiarrhythmic medications. And this is the same slide I showed you earlier with the antiarrhythmics having low yield, but with ablation, the significant difference we see here. And again, in other studies showing progression of atrial fibrillation after cryoablation or drug therapy, we realize that the cumulative incidence of persistent atrial fibrillation is much less in the ablation group compared to antiarrhythmic groups. And we know the efficacy of cryoablations, RF ablations, PFA ablations are all about the same. So there's no significant difference between them. If it works for one, you could assume that the other ones will have similar efficacy. Now, we'll talk a little bit about catheter ablation in the last few minutes of our talk. Today, there was a very nice expert consensus statement on catheter and surgical ablation of atrial fibrillation that published this year. Actually, very interesting, a very busy slide, but we're just going to go over the first couple of ones here, which I think is quite relevant. It says catheter ablation of AFib is beneficial in symptomatic patients after at least one class 1 or class 3 drug usage, but also it's advised to do is catheter ablation of AFib is beneficial as first-line treatment in symptomatic patients with recurrent paroxysmal atrial fibrillation. Initially, when the guidelines came, this actually did not exist. It's been added over the past few years that you could do as a first-line treatment. And in terms of risk factor modification, it's definitely advised to do is comprehensive management of AFib risk factors should be undertaken to improve the outcome of catheter ablation of AFib. So if a patient comes to us with BMI of 45, it is very appropriate to tell the patient, let's work together, let's lose some weight, let's get your BMI below at least 40 or 35, and then we can proceed with having an ablation to have a better outcome. Now, different catheters are available for the mapping. Different companies make different catheters. We have Abbott that does Advisor HD grid. It has several electrodes that is very easy to make famming of the atrium. Famming means you touch the walls of the atrium and create a 3D geometry of the atrium prior to your ablation, where also reflection AD, different forms, less used, but also helpful. Biosense Webster has laser catheter that opens and closes, a very atraumatic catheter that actually can do the entire left atrial mapping. Besides showing you the structure, but also these electrodes, they measure the voltage. So you know where the healthy tissues are and where the scar tissues are. I know we're going to be talking about MRI and scar and all those things with next presentation. But one way to identify the scar tissue in the atrium is by touching the walls of the atrium with this catheter and identifying the voltage. We'll talk about that. And then Pentray has got 5 arms and Optray 8 arms, and Optral is coming to the market, and also Biosense Webster has this. So different catheters available to be able to collect the data from the atrium. This is how the 3D mapping looks like. This is the posterior wall. This is the left superior vein, left inferior, and front of it is the appendage. Right superior, right inferior vein. Often resembles very, very closely to what CT scan would show that often we do prior to the ablations. And when the tissue is very healthy, we usually give a color purple, and at least with this modality, that means the amplitude of the signals are healthy, in a healthy range. When it's red, means there's no signal. So in this patient had point-by-point ablation, RF ablation. After the procedure, person identified that the veins are isolated. Now here we see that the ablation is done, but the vein posterior wall is not isolated. So it has some more work to do, probably some gaps. Now, types of ablation, we have radiofrequency ablation, cryoablation, laser ablation didn't take off as much, and pulse field ablation, which is a new one. Last few words about pulse field ablation, which is a new modality we're using now. So it is a non-thermal energy, so that's the good thing about it. It does not produce heat. Uses ultra-rapid electric fields. It's the same as DC, basically with the DC cardio versions. So DC, direct current energy, creates very small, tiny holes or pores in the membrane of the cells, and therefore causes influx of elements into the cell and causes derangement of the intercellular structure, and therefore leads to cell death and apoptosis. The process of creating holes is called electroporation, and it's an irreversible. So once you apply it, that cell is gone. It's not going to come back. It's highly selective. What it means is only affects the myocardium or atrial tissue, so it does not cause collateral damage to surrounding structures. We'll talk about in a second. So the advantages, behind the heart, behind the left atrium lies the esophagus. That's what we worry about when we're doing RF ablation, that we heat up the esophagus, we cause ulcers in the esophagus. And in rare occasions, probably 1 in 2,500 cases, you can have atrial esophageal fistula, which is a devastating complication of atrial ablation. But with the PFA ablation, you don't have that issue because you're not heating up the esophagus. It doesn't damage blood vessels. It rarely can affect the pericardium. And the nerves, especially the phrenic nerve, doesn't get damaged. It could get damaged with RF ablation. It's very efficient time-wise and does not cause collateral damage. Now, different catheters are available. This is the Medtronic that does produce Pulse Select, by Boston Scientific Farapulse, and Johnson & Johnson now has proved Varipulse, and then Cardium has proved. So different catheters, basically you put it at the os of the atrium and you apply, and what happens is this is exactly what we do, is we put it at the os of the vein, each vein, and there are 5 impulses we give. After that, the signals that you had here, no longer you see, so the vein is isolated. And then you go back with the catheter, which is what we do here, identify, make sure that the vein remains isolated. Each vein, we give about at least 8 pulses like this, so 8 times, to make sure that we have adequate ablation, so there will be no recurrence. So in conclusion, significant progress in understanding and management of atrial fibrillation has been made over the past few years. Risk factor modification, I cannot overemphasize, very important, is very effective and very important in the management of atrial fibrillation. Antiarrhythmic medications have not shown significant efficacy in the management of AFib, and their side effects often leads to their discontinuation. Although, having said that, we still use them often because in a lot of cases, As patients, we still need to use antiarrhythmics. Atrial fibrillation ablation, whether RF, cryo, or PFA, have shown promising results compared to antiarrhythmic medications. And the PFA, which is new modality, has better safety profile compared to previous ablations with RF and cryo, although the outcome in terms of vein isolation are very similar. The time of the procedure is shorter. These are my references, and thank you very much.
Thank you so much, Dr. Shafi. That was an amazing overview. You covered a lot of ground in a very short time. It was very useful for us non-EP. I see some hands raised in the attendees. We'll keep the questions till the Q&A. So please, if you have any questions, send it in the chat and we'll take care of them in the Q&A section. Moving along with the program, it gives me great pleasure to introduce the next speaker, my colleague, Dr. Saifuddin Abdurrahman, who is a cardiologist and cardiac imager from SSMC. Dr. Saifuddin has special expertise in cardiac CT and valvular heart disease. He's going to cover the role of cardiac CT in preparation for catheter-based intervention in AFib. Saif, take it away.
Sure. Good evening, everyone. You're seeing my slides? Okay, great. So yeah, so thanks for the introduction. I'm working at the moment at SSMC. Previously, I was working for over 15 years in one of the largest structural intervention centers in the UK. And I'm currently the director of the Echo Lab at SSMC. So it's a big topic in 15 minutes. So I decided mainly to concentrate on CT. Advancing my slides. So just an overview of what we're going to cover. So I think we're increasingly aware that, at the moment AF is diagnosed, it's a marker of cardiovascular risk. So obviously we're going to be using CT to screen for coronary disease in these patients. We'll cover how we can use CT for planning our ablation procedure and hopefully getting a better outcome. Still, the gold standard for detecting left atrial thrombosis transesophageal echo. But I want to spend some time covering the current evidence base that we have for how good CT is and how close we are to making a switch to CT for excluding left atrial thrombus. Then we'll touch on using CT for planning left atrial occlusion. And then finally, we'll just talk about how we use CT for detecting post-procedural complications. So as mentioned, increasingly the guidelines have moved towards recognizing AF as a cardiovascular risk factor. So the moment we detect AF, in addition to the precipitants like obesity, which has been discussed, we should also really be thinking about the risk factors, cardiovascular risk factors, and addressing those. And one of those things, of course, is screening for coronary disease. Particularly the aged patients, we might find that they have significant coronary disease. And as these people are going to be coming for CT, we may as well look for significant coronary disease, as was updated in the most recent ESC guidelines for AF. So just moving forward, so how are we using CT for the pre-procedural planning? Well, this is really twofold. My EP colleagues really want to know the venous anatomy in detail. This helps them plan the procedure, but it also helps because only 70% of patients have a standard pulmonary vein anatomy, so 2 right and 2 left pulmonary veins draining into the atrium. So by definition, 30% of patients have an atypical anatomy. And common variants include a common ostium. So this will be where the 2 inferior and superior veins unite before they enter the atrium. Accessory pulmonary veins, either on the right or left side, or late fusion of the veins. So this is where they fuse quite close to the common ostium, within 5 millimeters of the common ostium. So just to show you some examples of the things that we find in CT. So this is an example of a right middle pulmonary vein, which has quite a late drainage. You can see on the right side that you have the main ostium and then the separate ostium of this middle pulmonary vein. Second example. I can hear some background sound, so perhaps someone's not muted. Oh, that's great. Thank you. So here is an example. If we hadn't have done the CT, you wouldn't have known that there was an accessory vein here. And even this patient has two anomalies. So they have a middle coronary vein shown by the yellow arrow, and then the purple arrow, they have an accessory pulmonary vein as well. And obviously, if the EP specialist is going in, not knowing about this anatomy, then potentially these veins won't be isolated. Another common example is a common left ostium. So in this case, you can see the right superior and inferior draining separately. On the left side, you only have one common ostium. And here is an example of an accessory pulmonary vein on the left side. So there is more variation in the anatomy as compared to the arterial anatomy, with 30% of people having atypical anatomy. So it's very useful for the EP colleague to know about this before they start their procedure. The other reason why we might do a CT is because increasingly, although hopefully with this new technology, we'll be having less patients coming back for redo procedures. But we want to know before we do the second procedure if there are any complications left over from the first procedure. So I know later on we're having one case of pulmonary vein stenosis. We also want to know if there's any atypical position of the esophagus, particularly if we're using high energy devices where there might be an increased risk of fistula formation. And then the last thing is we can use CT to exclude thrombus in the left atrium. We never want to enter the left atrium if there's thrombus either in the atrium or the appendage, which is actually found in about 2% of patients on screening pre-procedure. I haven't included many slides about the procedural guidance, but obviously once we've done the CT, we can form a 3D data set, which then can be fused with live imaging in the cath lab to hopefully make the procedure quicker and smoother for the EP operator. Example that we did a couple of weeks ago, myself and Mario, and I'm sure he'll talk about that in further detail. So I just want to move on now and spend some time talking about the evidence behind how good CT is for the detection of left atrial thrombus. This is one of the largest systemic reviews and meta-analysis published in American Heart Association journal in 2021, so it's pretty recent. This included 27 studies, total of around 7,000 patients. And you can see that the sensitivity of early imaging, so let me just explain first of all what early imaging is. So when we do a cardiac CT, a normal cardiac CT for looking at the coronary anatomy, we time the scan for the arrival of the contrast in the proximal ascending aorta or the descending aorta. And this triggers a first pass arterial phase scan. So this is what we call an early imaging scan. But we've increasingly become aware that in order to be better at detecting thrombi in the left atrial appendage, we have to do delayed contrast imaging. So this means that instead of doing just the initial first pass scan, we actually do a delayed scan after 1 minute or 3 minutes or all three phases. And it's been shown in the studies that the late scans are more sensitive and more specific for the detection of left atrial thrombus. So with early imaging, the sensitivity was only 95% and the specificity was only 89%. When we start to include the delayed imaging, sensitivity increases to 98% and specificity increases to 100%. So much better doing the late imaging phases. So just on the right side are the forest plots. So this is for the arterial phase scans. You can see that really the sensitivity and the specificity is not where it needs to be. really 98% is not good enough if we're going to do a left atrial ablation and potentially cardiovert the patient in the procedure as well. I'm sure that we wouldn't want to do that with knowing that 2% of patients have missed thrombus. So if we include the late phases at 1 or 3 minutes, the sensitivity and specificity increases significantly. Another useful paper which looked at the diagnostic value of the late phases for detecting the thrombus. So this, just going back, so this was published in 2022 in Frontiers in Cardiovascular Medicine, and they screened 6,500 of their patients. The criteria is that the patient had to have a transesophageal echo, which was used as the gold standard, an arterial phase scan, and then a 1 and 3 minute delayed CT contrast scan. This brought together 329 patients, which they then looked at. If you have a look at the specificity that they found, so for the early phase, the specificity was only 0.54, increasing to 0.93 at 1 minute, increasing to 1 at 3 minutes. And the positive predicted value was also significantly better with the delayed contrast enhancement. So really, if we're going to be using the CT to detect the thrombus, we really need to be including these late phases within our scanning. And just to demonstrate why, so this is what we see in the atrium in our normal cardiac CT that we're looking at the coronary arteries. So there's a high amount of contrast within the atrium, and you have contrast streaming, which makes it look in many patients like there is thrombus there. So you're either gonna overcall thrombus or undercall thrombus. This actually patient does have some thrombus there. If you then do a 1 minute delay, you can see that all the contrast streaming has disappeared. We can still see that the thrombus is there, and then at 3 minutes, you can still see that the thrombus is there. So this is the way that we really should be doing it to exclude thrombus by CT. So where have we got to? I mean, we're all used to using transesophageal echo, but how many of us are actually using CT to actually exclude thrombus solely without doing a TEE? So it's useful to look at this a straw poll, which was done by the ESC, European Heart Rhythm Association, which was a survey. And they surveyed 48 major centers around Europe. TOE was the first line imaging test for 94% of the centers. Most of the centers were only using CT as a second line. And in many of the cases, in 52%, they would only use it if there was uncertainty on the TE. So although there is some evidence base for its use, as I've demonstrated, still most centers have not really moved to using CT. I think we're still relying on the transesophageal echo. Is it absolutely necessary? Is it absolutely necessary to have a CT? Probably not. There are a number of studies that show that actually pre-procedural CT doesn't improve safety and efficacy and increases the cumulative radiology exposure. But I think this is a moving evidence base. I mean, obviously our technology is improving, so radiation doses are coming down. And of course, a lot of the early studies were done with the arterial phase. They weren't using delayed phase imaging. So I think as we use more advanced scanners, the radiation dose will come down. And I think really, if we're going to improve the outcome of these EP procedures, I think we don't want to be missing unusual orientation of pulmonary veins, which might mean that a pulmonary vein is left unisolated, leading to the need of a second procedure. So I think certainly in our center, my EP colleagues are now requesting a CT for most patients that they're doing. So just briefly, I was asked also to talk about CT for left atrial occlusion. Of course, there are some patients that we have who are high risk for thromboembolism, but we can't anticoagulate them either because they've had significant GI bleeds or significant intracerebral bleeds. So some people are moving on to left atrial occlusion. In many centers, we're still relying on measurements and pre-procedural assessment by transesophageal echo. But the data is also pretty good for CT. There's just some technical considerations. So those of you who do left atrial appendage occlusion will know that it's easier to do the procedure in a patient who's in AF because the atrium is stunned and the appendage itself is stunned and not moving very much. So in the case of a patient who's in AF, perhaps it doesn't matter about the phase that you do the CT in. But certainly it matters if you're in sinus rhythm because throughout the cardiac cycle, the size of the appendage will be changing. So in order to do the scan, we do the scan in exactly the same way that we do it to assess the coronary arteries. So it's a first phase, early phase contrast scan. But we have to time the scan so that it's actually in ventricular systole. So usually we do this at a phase of 30 to 60%. Can be prospective, so we can only just include the systolic phases. But if we want to look at the coronary arteries, we often include the systolic phases, 30 to 60%, and the diastolic phases, 70 to 80% as well. We then get our 3D data set. We rotate the imaging so that we've got the appendage visible, the left upper pulmonary vein, and the left circumflex. We change the orientation of our crosshairs so that we're crossing through the circumflex and the pulmonary vein. And then we take the measurements of the ostium of the left atrial appendage accordingly. And I'd just like to show you all that this is a really good review article, which was an expert recommendation on how we can use cardiac CT for planning transcatheter left atrial appendage occlusion. And if any of you are considering using the CT, it's really a good read. And it will give you an exact way of taking the measurements for the different devices that are out there, either the Amulet device or the Watchman device. So then just moving on, particularly in, so one of the things that I was doing a lot in the UK was using the CT for planning valvular intervention. We were a test center for a lot of the first in human TAVI trials. So really you can use the CT to start actually using 3D planning of on the computer of how 3D modeling in the computer of how the different devices will fit into the left atrial appendage. So we can also use the 3D data sets for that. We can also use it for fusion imaging in exactly the way as we're doing for the AF ablation, for guiding the case and hopefully making it smoother and quicker in the cath lab to place the left atrial appendage occlusion device. And then finally, we can use CT to help us detect the complications of AF ablation. I mean, unfortunately, complications are not that common. Sometimes we do see patients who are left with pulmonary vein stenosis, as in this example here. And sometimes we pick this up when the patient are coming for their second AF procedure, and then we repeat the scan and we find that there's a change. So that's what I have to say. And I hope the talk was informative, and hopefully we'll take questions later. Have a good evening, everyone. Thank you.
Thank you, Saif. That was really awesome. I really enjoyed that talk. It was fantastic. All right, so moving on to our next speaker, Marion James from SSMC is going to be talking about AFib ablation in the DCAF era. I'm actually really excited to hear this talk and how Mario is going to incorporate some of the data from the DCAF2 study into this. So Mario, please take it away.
Good evening. Can you guys see my screen?
Yes.
Awesome. I just have to, sorry, I can see it. I'm glad you can, but what's happening here? Hey, very good. So thank you for the introduction. And so again, the topic I was assigned to cover is atrial fibrillation ablation in the decaf era. And when we talk about decaf, we talk specifically about using MRI imaging to assist us with atrial fibrillation ablation. And then what I'll try to cover here is the primary message out of the trial, and then we're going to go over some lessons that were learned from secondary analysis out of this study, the decaf trial. So unfortunately, despite having many trials over the last 10 years for catheter ablation, we seem to be doing really well when it comes to paroxysmal atrial fibrillation, with success rates around 75% to prevent arrhythmia recurrence. But when it comes to persistent atrial fibrillation, studies have shown that our recurrence rate continues to be somewhere between 40 and 50%, unfortunately. And that's why when it comes to persistent atrial fibrillation, we seem to need a little bit more than what Dr. Fraidoun has shown in his presentation, where we isolate the pulmonary veins and can really control paroxysmal atrial fibrillation. And for that purpose, the studies have looked at doing extra ablation on top of pulmonary vein isolation. And the landmark study was the STAR-AFib trial for persistent atrial fibrillation, where linear ablation, so creating lines within the left atrium, or tackling complex fractionated electrograms inside the left atrium, which are supposed to be areas of fibrosis, was studied. And unfortunately, in this study, those two techniques, linear ablation and cafe ablations, did not add really any added value on top of pulmonary vein isolation. Another also more recent study is the CAPLA study, where in addition to isolating the pulmonary veins in persistent atrial fibrillation, investigators looked at isolating the posterior wall by creating this box and many times ablating within the posterior wall to make it silent. And again, this study failed really to show benefit of posterior wall isolation on top of pulmonary vein isolation. Now, why do we need MRI? We have to go back and look at the pathophysiology of atrial fibrillation, and Fraidoun also presented this very nicely. But a very important part in atrial fibrillation, and specifically in persistent atrial fibrillation, is structural remodeling. So the atrial myopathy and atrial fibrosis, which can actually make those triggers, creating atrial fibrillation, sustain atrial fibrillation, and make atrial fibrillation persist in the left atrium. And now we have a really nice tool, which is cardiac MRI, to analyze atrial fibrosis. And this is a quick sequence just to show you how this is being done. So the MRI can actually segment the left atrium out of the image. And then what you can see over here is areas in blue and areas in green. Areas in green are areas of delayed enhancement, which correlate with fibrotic tissue within the left atrium. So now we have a tool that can show us the areas of scar and fibrosis within the left atrium, and that tool is MRI. Unfortunately, fibrosis is not just a focal problem that stops in time, it is a progressive issue. And then we know that if we image atrial fibrillation patients multiple times, many patients will continue to progress in terms of their fibrosis burden. And fibrosis progression is quite harmful. So it has been shown that fibrosis can correlate with increased risk of stroke, increased risk of cardiovascular death, increased risk of heart failure, and decreased mechanical function of the left atrium with decreased strain. So this is the reason why the investigators of DCAF conducted the first DCAF study back in 2014. We'll mostly focus on DCAF2, but I'll give you this as a background. So Dr. Marouche and his group, which used to be at University of Utah at that time, so analyzed cardiac MRIs and took patients for atrial fibrillation ablation. And they stratified their amount of atrial fibrosis in 4 stages. So stage 4 being more than 30% of the atrial tissue being fibrotic, and stage 1 being less than 10%, and 2 and 3 being in between. And this study did show that patients who went for atrial fibrillation, their outcomes were pretty much determined by how much fibrotic tissue they had in the left atrium. And for those who had more than 30% fibrosis, they really did not do well and failed to maintain sinus rhythm on the long term. And the opposite is true. People who have very little fibrosis tend to do better with pulmonary vein isolation and ablation of atrial fibrillation. So this background led the investigators to conduct this second study, which is the DCAF2 study. And this is the study design. I'll tell you the rationale of it was very simple. If fibrosis is bad, can we ablate fibrosis along with isolating the pulmonary veins to improve our outcomes? And this is exactly what the study tried to do. So they randomized patients with persistent atrial fibrillation who had a baseline MRI looking at their left atrium. And then within 4 weeks of that baseline MRI, they were randomized to either receive pulmonary vein isolation alone or pulmonary vein isolation plus targeting of the fibrotic areas highlighted by the cardiac MRI. So fibrosis ablation plus PVI or PVI alone. All patients had a follow-up cardiac MRI about 3 months after the catheter ablation to look at ablation lesions to see how much lesions did we create from ablation, which can be distinguished from fibrosis. So MRI can distinguish between fibrotic tissue and between a lesion, which is due to the ablation process itself. And patients were followed with daily EKG transmissions and routine clinical follow-up to look at atrial arrhythmia recurrence. Unfortunately, the study was negative. So patients who had pulmonary vein isolation alone or patients who had pulmonary vein isolation in addition to fibrosis ablation had the same rate of recurrence of atrial arrhythmia. There was no benefit of ablating beyond the pulmonary veins. The recurrence was 43% with pulmonary vein isolation alone. Sorry, it was 43% with pulmonary vein isolation and ablation of the fibrotic areas, and was 46% when only the pulmonary veins were isolated. So not only this, unfortunately, safety outcomes were also alarming. So in patients who had fibrosis-guided ablation, they tended to have more adverse outcomes, and specifically here, more strokes. So there was 6 strokes in the fibrosis-guided ablation group. There was no strokes at all in the PVI group. And 6 stroke, which is 1.5% incidence rate over here, is quite a high rate of a stroke in an atrial fibrillation ablation population. We obviously don't want to see this. So the primary message out of this DCAF2 trial is the following. Pulmonary vein isolation remains the cornerstone at the index procedure, even in patients with persistent atrial fibrillation. We have to keep in mind that if we ablate fibrosis, we could potentially also be increasing the risk of stroke. But we shouldn't stop here. There was a number of additional lessons that we could actually derive from DCAF, and that the study investigators actually published in multiple manuscripts. And I'll try to cover those as quickly as I can. So in one of their secondary analysis, they looked at pulmonary vein isolation. So electrophysiologists among each other, each one of us does the pulmonary vein isolation in a different way. Some people go ostial, some people go enteral. We don't agree exactly on how to do it. In this study, it was shown that no matter how we do the pulmonary vein isolation, as long as we do it right, whether it's ostial or enteral, outcomes really did not differ between the different PVI strategies. Also, in that same analysis, they analyzed patients who had posterior wall isolation on top of PVI, and it did not seem that posterior wall isolation added benefit in this study particularly. The second lesson, or the second analysis that was also done, and I believe this is extremely important, and this is probably a matter of debate, that if we really say that we're gonna ablate fibrosis, we should not take for granted that we truly ablated fibrosis. So if we put those red dots over fibrotic lesions, this does not really mean that we ablated the area and created a real ablation scar. So I'll take you back to the study design, if you remember, that I showed you a few slides ago. And this is the group that had fibrosis-guided ablation plus PVI. And within this group, when they looked at the MRIs that were done after ablation, only around 45% of those patients had more than 40% of their fibrotic area covered. So really not that much of the fibrotic area was covered. And when we look at the PVI, only 15% had their fibrotic area covered by more than 40%. This is not just because the operators were lazy or did not want to do more ablation, but what this study also showed in patients who have dense scar and have too much scarring, lesion delivery becomes an issue. So when we deliver radiofrequency or cryoablation, we cannot achieve the same results that we achieve in healthy tissue and in patients who have less fibrosis. Well, what's interesting in this secondary analysis, when they analyzed patients who had at baseline less than 20% of their atrium being fibrotic, and when they looked at within this subgroup at patients who really had their atrial fibrosis covered by ablation, it seems that if they were really ablated correctly and the ablation, the fibrotic areas were covered, those patients did derive benefit and had a lower recurrence of atrial fibrillation. That only applied to patients who had at baseline less than 20% fibrosis in the atrium. And this was actually published, the article is still in press, from September 2024. And again, the conclusion is that radiofrequency ablation lead do not uniformly result in scar formation, but a post-hoc analysis suggests that reduced arrhythmia recurrence when ablation-induced scarring covers fibrotic regions in patients with low baseline fibrosis. So again, if you have little fibrosis, less than 20%, and you can cover it and you can do effective lesions, you might benefit from doing additional ablation to the pulmonary vein isolation. And another secondary analysis is looking at the pattern of fibrosis in the left atrium in atrial fibrillation patients. And this is also important and interesting. So it seems that the place where we have the most fibrosis is the left pulmonary veins. This is where most of the fibrotic areas are seen in atrial fibrillation patients. And this could be the reason why we actually do quite well with pulmonary vein isolation, because when we isolate the pulmonary veins, we're actually ablating the left antrum around the pulmonary veins, and we're eliminating those areas of scar. Another analysis also is what they called entropy, which sounds quite complicated, but I'll try to simplify it. So essentially, they have a formula that can look at the percentage of fibrosis in each segment of the MRI. And this formula is essentially trying to tell us, is the scarring aggregated in specific areas, like you see on the left of the screen here, or is the scarring actually scattered and just distributed almost evenly within the left atrium? So if you look at those two graphs over here, both potential patients have the same amount of fibrosis, but in one patient, the fibrosis is aggregated, in the other patient, the fibrosis is scattered. And this difference seems to be important because people who have scattered fibrosis seem to do better. So they have lower atrial fibrillation burden. And not only this, they seem to derive more benefit from atrial fibrosis ablation. While patients who have more aggregated, dense scar, they actually have a higher atrial fibrillation burden, and they don't respond very well to ablation of their scar. So with this in mind, is there still a role for substrate modification beyond what we call pulmonary vein isolation in persistent atrial fibrillation post-decaf trial? Well, I believe there is still a role. I would like to highlight this study from 2022 called the ERASE Atrial Fibrillation Trial. The investigator in this study did not look at cardiac MRI scarring, but they did a voltage map, like Dr. Freidoun had mentioned in his talk. And the voltage map will show us areas of low voltage that should correlate with areas of scarring in the left atrium. And what they did in this study that, again, they randomized patients to either have pulmonary vein isolation alone for persistent atrial fibrillation, or to undergo pulmonary vein isolation and ablation of those low voltage areas or areas of scar. But what they did differently is that they actually pre-specified how we should ablate the scar. And in each segment of the heart, they recommended a specific pattern, how ablation should be done. And not only this, they actually were very strict about the endpoints of ablation, meaning making sure that we truly ablated that area of scarring. We can no longer capture when we pace within the scar. And if we created lines, to make sure that we connected those lines to anatomical barriers, and we truly have bidirectional block, or what we call block of the activation throughout those lines. And this study was actually positive. So that did show that we can derive extra benefit when we ablate the scar on top of doing pulmonary vein isolation. What this study also showed is that not all patients with persistent atrial fibrillation have scarring. Only 1/3 have scarring. And the presence of scarring by itself is also an important prognostic factor because it does correlate with AFib burden and the risk of recurrence of atrial fibrillation. So just to summarize at least how I use this data in my practice. So when I'm dealing with a persistent atrial fibrillation, I'm doing the first-time ablation. So most importantly, we have to do a very solid pulmonary vein isolation, make sure that we truly isolated the veins. But then we can do more. We can do accurate voltage mapping of the atrium. And in my practice, if I see scarring in the posterior wall, I actually do isolate the posterior wall, but I just do not create a box lesion. I just ablate within the posterior wall until I make sure that the entire wall is silent. And then we can do more. We can look for extrapulmonary triggers, and then we can try to induce flutters. And if we induce flutters, we treat those flutters with lines. But whenever we do a line, we have to make sure that we can do a complete line and that the line will actually be a permanent as much as possible line to prevent flutter recurrence. We're very excited, and also Dr. Freindou mentioned this, that now we have new tools that we can use for atrial fibrillation ablation. And at SSMC, where I practice, I'm very happy to say that we have already used all 3 new tools for pulse field ablation, starting with the Boston Scientific FARAPulse, which seems to be a great catheter to isolate the veins, but also to ablate the posterior wall. So that's something that can be done. And even linear ablation, mitral isthmus, cavo-tricuspid isthmus ablation. I know the catheter is not approved for this, but those have been done by many operators, and we have tried to do that as well in our lab with good success. Other catheters from Biosense Webster are also available, seem to be also a very good catheter to isolate the vein, and Medtronic also has a Pulse Select catheter, which we have used and seems to be really good for pulmonary vein isolation. So the beauty about those catheters is that we can actually, once we are comfortable using them for the veins and we start using them to ablate scar outside the veins, using those catheters seems to be safer, and we should be able to tackle the posterior wall without significant concern about affecting extra cardiac structures. And we do hope in the future that the lesions that are delivered with pulse field ablation are not only sure, but hopefully will achieve more persistent ablation and potentially in the future, maybe better outcomes. With this, I'll stop, and I'm happy to take any questions at the end.
Thank you so much, Mario. That was amazing. A lot of technical details, but perhaps necessary to discuss to see how we're coming along with this in this field. A question from the audience that I will direct to Dr. Saif. To stay on time, we'll take a couple of questions before we move on to the next segment. Question, Dr. Saif. The delayed imaging, does that increase the dose of contrast and or radiation? Can you clarify?
Yeah, sure. So it doesn't increase the dose of contrast because we're giving the same bolus that we do for a normal coronary CT, but we're actually repeating the scan once or twice for the delayed contrast imaging. So essentially, we give the bolus of contrast. We time the scan for the contrast arrival in the superior vena cava. In the ascending aorta or the descending aorta, depending on what your scanner's like. Different ones are set differently. So that triggers the first arterial phase scan, which is the same scan that we use to look at the coronary arteries. And then we repeat the scan, having given that bolus. We don't give another bolus at 1 minute, and then we repeat the scan at 3 minutes. So essentially, if you do it at 1 minute and 3 minutes, you've got 3 times the radiation dose. But many centers are just doing it at baseline to look at the coronaries, and then they're doing at either 1 minute or 3 minutes. So it will be double the radiation dose, but the same bolus of contrast.
But correct me if I'm wrong, Saif. You only take a slab that includes the left atrial appendage. You don't scan the entire field of view when you do the delayed imaging, because your focus is the appendage.
Yeah, so you can reduce the dose by just focusing on the appendage, but the first pass imaging, we're also going to look at the coronaries as well. because many times we want to screen for coronary disease. So in the first image set, we'll include the whole heart. The second and third image sets, you can reduce the field, but that's not possible to do with all scanners. That's the problem. Depends what model of scanner you've got. Some of the one heartbeat scanners, they do the second and third phase so quickly that you really can't change the parameters. So you just have to repeat the same parameters. So it just depends on what model of scanner you've got.
Great. A question I'll direct to Dr. Faridoon. Dr. Faridoon, is there a role for antiarrhythmic medications when or after you apply a pulse field ablation? You're on mute, Faridoon.
Do you hear me now?
Yes, yes.
So usually when we do ablations, by definition, we create inflammation inside the heart. So usually we would like to do for a period of 1 to 3 months post-ablation to provide patients with some sort of antiarrhythmics. During this, we'll call it gray zone or gray time, that first 3 months due to inflammation, patient could have recurrence of atrial fibrillation, and the medication usually calms the heart down. But the plan for post 3 months is to taper down or stop the antiarrhythmics and patient be antiarrhythmic medication free. So the answer is yes. For the first 1 to 3 months, we normally, majority of us use antiarrhythmics.
So I have a question for Dr. Niam. So Mario, great talk. I really enjoyed it. Good question. Do you see a role for the catheters that can toggle between RF and pulse field? And if so, what do you think the role for that kind of catheter would be?
Sure. Thank you. So, I mean, obviously, those catheters, especially when you're ablating the posterior wall, so you could be using PFA where you want to really be sure that you're not damaging the esophagus. And then we obviously need more data to see the persistent or long-term effects of PFA, but I see potential to use more RF when you're ablating thick tissue anteriorly, like the ridge and the anterior left antrum and maybe the right superior roof, those areas that could potentially be better targeted with radio frequency. But I guess that we just need more data about the long-term effects of PFA and to be able to compare how this compare with radio frequency. But as you're alluding to, so many catheters are being developed or are already exist that can actually deliver both energies, and you can toggle between PFA and radio frequency. We haven't used them yet, but we're eager to try them.
Fantastic. So I think given time, we should probably move on to the cases.
Sure. Sure. So I'd like to thank the speakers from the first section. If you have time, please stay with us as panelists for the next section. This is going to be a case-based discussion. I'm going to ask case presenters to go through your entire case as quickly as possible, and then we'll open it up for discussion and input from our experts, both EP and imaging. First, I would like to introduce Dr. Rami Baniata, who is one of our stellar cardiology fellows in Cleveland Clinic, Abu Dhabi, with many interests, including EP, who is going to discuss with us a case of left atrial appendage occlusion with focus on the role of imaging. Rami, floor is yours.
Thank you, Dr. Faras, for the introduction. Can you see my screen, Dr. Faras?
Yes, we can.
Okay. So good evening, everyone. So I'm presenting a case with a topic of persistent AF with intracranial hemorrhage. So I don't have any relevant disclosures. So my patient he is a 90-year-old male patient with a previous history of the following. He is ex-smoker, coronary artery disease with a history of PCI to his left circumflex in 2023. He is diabetic, hypertensive, dyslipidemic, CKD stage 3. He is a known case of congestive heart failure with a recent AF of 45%. He had a persistent AFib and he was on edoxapan. He had also moderate severe TR and COP.
Ramin, sorry to interrupt. Can you go to slideshow, please? We're still on the title slide. Sorry.
Is it working now?
At the bottom, go to the slideshow or hit F5.
Yes.
Okay.
Is it working now?
Yes,
Dr.
we're still on
Firas?
slide.
Is it working now, Dr. Firas?
Now it is, yes. Now it is.
Yeah.
Go for it.
Sorry for the delay. So again, he's 90 years old. He's ex-smoker with a history of coronary artery disease with a BCI to the circ in 2023. He's diabetic, hypertensive, dyslipidemic, CKD stage 3, congestive heart failure with EF of 45%. He's also known case of persistent AFib on edoxapan, moderate to severe TR on echocardiogram and COPD. So the patient was admitted to the hospital after a fall at home, and cardiology got to contact with this patient after we were consulted during his admission for management of his AFib. So this is his ECG, which shows AFib. No acute STT changes as we can see here. So during his presentation, after he was having a fall at his home in the emergency department, he had a CT brain without contrast, which shows a right and left subdural hematomas. So he got admitted. His anticoagulation was interrupted, and he got to be monitored in the hospital for 2 to 3 weeks. In 3 weeks, they repeated his images, which showed some resolution of his subdural hematomas and some chronicity in this bleeding. So now we have a case when you usually encounter these situations, maybe on daily basis in our hospital. So this patient with a atrial fibrillation, persistent AFib with a high CHA2DS2-VASc score, he scores 5 points in the CHA2DS2-VASc score with a 10% risk of a stroke and TIA or systemic embolism yearly. With a high has bled score, he scores 3 points on that. So and the most important thing that he presented with subdural hematomas, so he have a bleeding. So what our options here? So can we just resume his anticoagulation after it seems or deemed safe from the neurology side, or we can just discontinue his anticoagulation because the patient, of course, he has a high risk for rebleeding. Or we can consider one of the options which is the left atrial appendage closure devices. So we opted to proceed with left atrial appendage closure. So we did for this patient TEE for evaluation and for sizing his left atrial appendage. So here we can see TEE showing the left atrial appendage here with sizing of the maximum diameter of the left atrial appendage. Some 3D images here. So to size it and to plan for a proper device size to include this left atrial appendage. So after that, we proceeded with the device. It was an AMOLED device, 28 device. So here we can see the device in the left atrial appendage. Here after the deployment of the device, and we can see here the tuck test, which we usually do to make sure that the device is secured well and there is no risk for embolism of the device if it was improperly sized. And here we can see some 3D images shows the device nicely seated in the left atrial appendage here. We recently saw this patient in the clinic. He is recovering from recent CVA insult. He remains on aspirin and no new bleeding episodes so far, and he reported no cardiac symptom of note recently. And thank you, everyone.
Thank you so much, Rami. Any comments from our EP and imaging colleagues on this case? Jack, any comments? Any questions?
Yeah, no, it's fairly straightforward. Good management decisions, obviously, wanting to get a patient like this off of blood thinners, and with all the most recent studies coming out about left atrial appendage occlusion, really, we're going to start seeing these devices, I believe, really start to really explode in the coming months to years. So, and just a nice case demonstrating the appropriate use of a left atrial appendage occlusion device. And again, I think we're gonna it will be quite interesting to me once, right now, I mean, this is still kind of a specialized field where people are doing a lot of these, but once this gets opened up and more people start implanting these devices, as the indications start to increase, it will be interesting when how patients are going to do with these devices when operators who only do a handful start trying to do them in the community around the world. It will be interesting to see whether, how patients will do with this, because, there's a whole kind of, I would say, almost like field about closing leaks around these devices at this point in time with coils and everything else. But I would love to hear from the staff, from the speakers, and what they think are potentially some of the concerns going forward about having left atrial appendage occlusion being put in all over the world by operators that are, only doing a handful.
There is one comment I would like to make about the selection of patients for left atrial appendage closure. We, in our institution, very similar presentations we've had before, patients, elderly, falls, head bleed, and so on, very well qualifies on the paper for implantation of left atrial appendage closure device. But when we look at clinical scenario, that's very important in decision-making at bedside. Some of these patients have significant advanced dementia, and once we decide, to put the left atrial appendage closure, we start thinking of like, what really are you trying to save here? So some of these patients we turn down because they really addition of a stroke is not going to make a major difference. They're already bedbound or on a PEG tube, whatever. So I think good selection of these patients is very important. That's what we normally do. And again, as Dr. Rickert says, when it opens up, then sometimes people may be more lenient in terms of implanting devices that may or may not be 100% appropriate.
Question two in the chat to say, do you prefer a CT scan before left atrial appendage, or is TE sufficient? And I guess when do you decide to use which? Dave?
Yeah, I mean, so if you're working in a high volume center, I mean, we're routinely doing the CT anyway, because we want to know the 30% of people who have a less usual venous anatomy. So it's going to save you time, because the last thing you want to do is to put the patient on the table, anesthetize them, and then do the TE and find that they have a left atrial appendage clot. So I think a lot of centers are using the CT. If you do it a few days before you do the ablation procedure, you can save unnecessary patients getting anesthesia, and save yourself some theater time. Because if you detect on the CT that they've got left atrial appendage clot, then you can replace that with another case. So if you're a high volume center and you want to get a lot of patients done, it's definitely worth doing the CT, I think. But I think you need. But you've seen in the meta-analysis there that the sensitivity varies from 98 to 100%. If you're getting a 98% sensitivity, most of us wouldn't be comfortable, not doing the TE. So I think this is like a screening that you can do a few days before, and you can take that patient off the list and put another one on if they've got appendage clot.
Great. Well, that was excellent. We'll just close this case with one last question. Jack mentioned already about para-device leaks or incomplete occlusion. What is the imaging modality of choice to diagnose those? Is it TEE, or do you see any role for CT on top of TEE?
So with, I mean, in addition to the tug test that you do after you put the device in to make sure it's not going to embolize, you do check on TE, the seal, live during the procedure. You can check the seal on CT as well. Of course, I mean, you shouldn't have contrast in the appendage if there's a good seal, right? But I don't really know many centers that are doing that routinely, to be honest with you. And then the question is if there's an imperfect seal, what are you going to do about it? And when do you actually do the CT? Because these devices are designed over time to endothelialize and to seal off small clots, small leaks. So when do you actually do the CT? Do you do it after 1 month, after 2 months, after 3 months? So I don't really know of any centers who are doing it routinely, to be honest with you.
Great. Thank you so much, Rami. That was an excellent case.
Thank you so much, Dr. Firas. Thank you.
So next, we'll have Dr. Ali Musawi from King's College, who will share with us a case of pulmonary vein stenosis, feared complication of AFib ablation. Ali?
Hi, thanks for kind invitation. Actually, my case is not typical case. I will review PV stenosis within few minutes. So. Now you have my slides?
Not yet.
Not yet?
Not yet, no.
Can you switch to the presentation?
Is there? I don't know.
If you share a screen, then go to the presentation directly.
I'm sharing the screen, but I don't know why. It's not coming.
For the sake of time, do you guys think we can move to our next case and someone can work with Dr. Ali offline? I want to be respectful of everybody's time here.
Dr. Ali, you can switch the windows, the open windows to open the presentation.
You can see now? Still no?
No.
Maybe we go to the third case. What do you think, Firas?
Sure. Ali, if you guys can give him some assistance offline, we'll share the third case. Agree. All right. So, all right. The third case is a patient we've seen here in Cleveland Clinic, Abu Dhabi. She's a 52-year-old woman with prior history of rheumatic mitral valve disease. She had a severe MS for which she received balloon valvuloplasty back in 2003. In addition, she has chronic systolic congestive heart failure with persistent atrial fibrillation and hyperlipidemia. She was referred to general cardiology clinic for evaluation of exertional dyspnea. Her symptoms can be best described as NYHA class 2. Medications include warfarin, bisoprolol, empagliflozin. She was on sacubitril valsartan in addition to ezetimibe, rosuvastatin. Her cardiologist started off with a basic investigations, including transthoracic echocardiogram, which showed an EF of 45%, which is similar to her prior ejection fraction. There was no significant change. There were rheumatic changes of the mitral valve with mild mitral stenosis, a mean gradient of 3 millimeters of mercury, and only mild mitral regurgitation. She's not known to have coronary artery disease, so it was felt that working her up for coronary disease would be the next step in management. And for that purpose, she was referred for a cardiac CT. I'm just going to show you a brief film that is relevant to this presentation and this session. I would like you to focus on her cardiac structures. Let it play again. So you can tell she has severe left atrial enlargement, right atrial enlargement as well. This is the left atrial appendage, and you can see that she had a filling defect in the apex of the left atrial appendage that was consistent with the left atrial thrombus. She was in AFib at the time of this performance of this study. The physician was called. She was anticoagulated, but the diagnosis of left atrial appendage thrombus was concerning, and the patient was subsequently referred for a transesophageal echocardiogram. These are representative clips from her TEE, which shows that she has, there's severe spontaneous echo contrast, reduced contractile function of the left atrium and left atrial appendage, but there was no definitive thrombus that could be appreciated. These are representative views at different angles. The operator at that point decided to use an ultrasound enhancing agent to exclude a thrombus more definitively, which was the case. There was no evidence of a filling defect after the use of contrast, and diagnosis of left atrial appendage thrombus was excluded. So the evaluation of the coronary vessels was limited, but it was felt that the patient does not have significant epicardial coronary disease. There was no left atrial appendage thrombus, but the patient continued on warfarin for persistent atrial fibrillation in the setting of rheumatic heart disease. This has already been covered by Dr. Saif. This is a different meta-analysis relatively earlier that shows if you rely on CT, you have a pretty sensitive test, and you can reliably rule out the diagnosis of left atrial appendage thrombus. The Achilles heel, though, is the poor specificity and the poor positive predictive value. So, like in this case, you may see a filling defect that is related to contrast layering and not really a defect. And the use of delayed imaging is what helps you. And as you see, there is a significant increase in positive predictive value with the use of delayed imaging. So you improve specificity. You are better at calling, ruling in and ruling out thrombi if you can combine angiography phase with delayed imaging. And this is what this looks like. This is a filling defect. This is a persistent defect in the appendage at 1, 3, and 6 minutes, which correlated with a thrombus on TEE, if we consider TEE is the gold standard. This is a different investigation from a group from Italy that showed what you really gain by adding delayed imaging is improving your positive predictive value. And by 6 minutes, if you wait to image them at 6 minutes, that's when your positive predictive value is the best. So this was a brief presentation. I'll open it for discussion and would like to hear input from my colleagues. Any questions or comments? Saif, go ahead.
Yeah, so obviously, you know, once you do, a lot of us who are doing cardiac CT are live in the scanner room. So we're seeing these images come through live. You're going to spot that defect. So you've got 3 to 6 minutes to do a second scan. So I think you know, if you see that, you can always do the second scan, which is going to give you a more definitive answer, because the specificity of the delayed phase scans are approaching 100%.
I agree, and this may be a logistical or a workflow issue, because a lot of times we are not in the scanning in the CT room while these scans are done, and we just receive them on the workstation in the list to read. So by that time, the patient is already gone. So that would be a missed opportunity. Great. I think we have Dr. Ali's case. Dr. Ali, are you ready to go?
Looked like we were getting somewhere, maybe not.
Doctor,
Hello?
click on you.
Hello?
Yes, Ali, go
Yes, we
ahead, please.
switch to the Canva. Yes. Flip. Yes, you can start.
You have the slides?
Yes, Ali, go away.
Okay. This is PV stenosis after AF ablation. So this is T view of this. Briefly, the typical case for this era is they are chronic AF patients. They usually came to us after one procedure of ablation. For redo ablation, we can see this PV stenosis in them. Our case had one ablation in 2015 for redo ablation without any symptoms. At 2022, we detect this problem. Pulmonary vein stenosis is very uncommon, devastating complication of AF ablation. Usually it's misdiagnosed because of lack of routine screening and non-specific symptoms, and can eventually ended up with pulmonary venous occlusion. In early studies, we could have found this problem in up to 46%. And these days, it's only about 1 to 3%. Symptoms of this PV stenosis usually is related to the number of affected veins, severity of stenosis, and physical activity of the patient. Even 4 to 8% of these patients severe PVS, they are asymptomatic. The symptom subtle limitation will happen within days. Fulminant symptoms usually 1 to 12 months. We can see. Imaging modality CT, MR venography. And basically, historically, 2004 to 2007, they used to use TE routinely 6 to 12 months after the procedure. After 2008, it's usually limited to symptomatic patients. Usually symptoms are related to severe stenosis of more than 70% or 60% stenosis in multiple veins, and usually can end up with irreversible PH. Treatment option is transcatheter intervention. 60% usually is unilateral, usually left pulmonary vein. 40% is bilateral. Usually is progressive and related to high mortality is also high. Changing ablation site, temperature reduction using cryo technique was the techniques that decrease the number of this complication. Usually we can see 79% dyspnea in the patients, increased PAP in 33%, 26% they develop hemoptysis. Usually almost all cases are asymptomatic. Mild below 50 or 50 to 70% of stenosis, usually they don't have any symptoms. The pathophysiology is usually reduction of 20-25% of lung perfusion with single pulmonary vein stenosis more than 70% or multiple pulmonary vein stenosis with more than 60%. If we leave asymptomatic patients, they can, without any treatment, usually thrombotic occlusion of the pulmonary vein will happen and cause occlusion of the pulmonary vein. We use peak gradient over 1 meter per second for diagnosis of PE. We can use contrast CT. We can see normal perfusion of right inferior, left inferior in this case, right superior, filling defect in left superior. We can use also 3D imaging for diagnosis of the complication. Treatment options, usually we go for treatment in symptomatic severe stenosis in multiple pulmonary veins. For asymptomatic, there is no dedicated guideline. And imaging monitoring every 3 to 6 months is recommended for asymptomatic patients. Treatment option is balloon angioplasty versus stenting. Stenting with large diameter stents are recommended. They usually have higher patency rate, and with stenting, even with stenting, we still have 20% of re-stenosis. After stenting, usually we use clopidogrel anticoagulation and follow-up CT before discharge, 6 to 12 months after the procedure. And that's PV stenosis of left upper pulmonary vein.
Well, thank you, Dr. Ali. That was a nice presentation. You know, one of the things, one of the great advantages of pulse field ablation is hopefully eliminating this complication potentially forever. And that's kind of one of the great things about pulse field that we do here in SSMC, and as well as here at Cleveland Clinic Abu Dhabi, we do lots of pulse field ablation for atrial fibrillation. And that's one of the advantages that we can tell our patients when we're consenting them for ablation, is that when you use pulse field, this really isn't the problem. When they looked at the data from the FAIR trial, a large trial that was published at HRS last year, there was zero incidence of pulmonary vein thrombosis in the PFA arm. And certainly, let's hope this is a thing of the past. And I'll open this up to the panel. Mario, what do you think as we go through pulse field ablation, as pulse field ablation really takes over? Do you think we're ever going to see this again, or do you think we're going to be surprised that pulse field may cause this in the future?
Well, I mean, as you mentioned, the data so far with all different studies with the different companies and different catheters for PFA have not really reported PV stenosis. So, in fact, some operators are now even advocating ablating inside the pulmonary vein, which I mean, in the past with radiofrequency, obviously, is the only thing you should not be doing. So it seems to be really safe, but again, as any new technology, we need time to know about long-term safety. The other thing, even when we use radiofrequency is not gone. We can still use imaging techniques like intracardiac echo. We can really make sure that our ablation lesions are as enteral as can be, and make sure that with ice, we're not putting our catheter inside the vein. And that reported 1% incidence, at least in clinical practice, I have not seen it being really 1%, but obviously we have to always remain vigilant and be careful that our technique is not actually promoting PV stenosis.
I have a question, you know, for when you guys do these procedures, you know whether it was done with this technique or that or the other. But when we as general cardiologists see these patients present with symptoms, I guess the question to Dr. Faridoon, you know, what would make you suspect pulmonary vein stenosis? And if you decide to work it up, the question to you and then to Saif, what is kind of the cascade of testing? What test do you start with and what do you go to next? So clinical presentation and imaging.
So clinical presentation for PV stenosis is actually quite confusing because it's a rare situation. You have to have high level of suspicion towards that. Very similar to atrial fistula, that is very rare situations often get missed. So majority of people come with non-specific symptoms. Patient may tell you that he's more short of breath than usual. If it's extremely severe, he may have you know, pulmonary congestion and all those things. But majority of time, patient just tells you, I don't feel well since we did the ablation. I feel tired. I'm not doing well. And if you looked at all the reasons for patient to be, you know, medication side effects, you know, just recovering from procedure and all those things, and you've not really identified, and this is going on for months and months. So you kind of wait a little bit to see if patient gets better and still keeps going on, or maybe even getting worse. In that case, it's a good idea to suspect possibility of pulmonary stenosis. Options of imaging. Obviously, Dr. Saif can allude to that in more details. You have the option of CT scan. You have the option of TEE to look into that. 2D echo probably is not that doesn't give you a lot of information on that, and I'll leave that to Dr. Saif for more explanation.
Saif?
Seem to have lost connection with Saif.
Well,
Yeah, we have lost connection. Okay.
yeah, looks like we've lost connection there.
Can I maybe make a quick comment to
Sure.
Firas' point? I mean, I believe our role as electrophysiologists is to really keep educating, because as you mentioned, and you make a very valid point, we use different techniques. We assume that the community or referring physicians know what we exactly have done. So we have to do a better job at educating. And then some imaging techniques will not really show any lesions. So if you do an MRI, you use the current technique in looking at ablation lesions post-PFA, you would assume that nothing was done, that there was no ablation at all that was done. So there are new techniques for MRI imaging being developed to really identify where the PFA lesion was. But the current technique that we use with radiofrequency will technically show you no edema and no traces at all that an ablation was done.
Great. Saif, CT, first line, second line, and what kind of CT? Like kind of close this section with this question.
Yeah, sorry, I dropped off the meeting there for a second. So, I mean, I think if you're suspecting pulmonary vein stenosis, I would go straight for the CT. I mean, number one, why subject the patient to a TE? I mean, in good hands, it's okay, but it's not a pleasant procedure still in any hands. And you don't always see all 4 pulmonary veins on the TE in all patients. So I would just go straight for the contrast CT. And we're going to use the exact same technique that we use for looking at the coronary arteries.
Got it. Excellent. Any last comments, Jack, before we move to the third part or last part of this session?
No, I think pulmonary vein stenosis is really one of those things where you really need a high index of suspicion, and the education is key. Knowing that when patients come in with these vague kind of pulmonary respiratory symptoms, that this should be on your radar. But let's hope this is going to be in 5-10 years. We're going to think about this as more of a historical interest rather than anything that's any more relevant once pulse field takes over the whole AFib space, which it's rapidly doing right now.
Great, great. Thank you, everyone. I would like to thank case presenters and panelists for their input. I would like to thank Dr. Ricard for his help moderating this session. And next, we will move to the last part of this webinar, which is with Dr. Zafar Khan from ICLDC, who will give us some update on recent advances in anticoagulation for atrial fibrillation. Dr. Zafar?
Hi, Faraz. Hi, thanks for inviting me. I'm not sure if my camera is working, so I'm just going to share my, where's it gone? This one, I think it is. Just bear with me for 1 second while I just get this up and running.
Or Zafar, I said ICLDC, I misspoke.
No, that's all right. I think you promoted me, so that's fine by me. That's okay. I can live with that. So yeah, I know it's getting quite late, and it's been a very intellectually, I'm not going to say challenging, but very intellectual session. So I'll try and go through these slides fairly quick. So I'm just going to talk briefly about advancing anticoagulation in AF patients. And, you've probably gone through a lot of these slides already. So the first few slides I'll go through very quickly. And, we all know that AF is a major risk factor for thromboembolism. And that's regardless of whether this practice is more persistent or permanent. And if it's left untreated, it can certainly increase your risk of stroke by 5-fold. And 1 in 5 strokes is related to AF. And we know quite clearly that the process of getting strokes is not a platelet process, it's a thrombus process, which is why the antiplatelet drugs have really not shown much promise in preventing strokes. And anticoagulation is really the only medication we have. I'm not going to talk about left atrial appendage occlusion, but the only medication we have is really the OACs. And so therefore the default approach really should be OACs in all eligible patients, except those who are at low risk of stroke. And we can see that the prevalence of AF has certainly increased significantly over the last 30 years or so, certainly from 1990 to 2020. You can see that the prevalence of AF in UAE has gone up by about 800%, which is significantly more than Bahrain. And that's for a number of different reasons. Certainly, we've seen an increase in hypertension and diabetes, increase in BMI over the last few decades or so, particularly in the Middle East. And as you said, this certainly increases your risk of stroke. So we need to ensure that we're identifying our patients and putting them on the most appropriate medication to try and prevent them from running into this really awful sequelae of atrial fibrillation. So I think the first thing really is part of the, I don't know if you guys, the audience have read the recent ESC AF guidelines. If you haven't, it's a big document, but it's actually a very, very, very good document. And if we look at the A aspect, which is avoid stroke and thromboembolism, there are certainly questions we should be asking ourselves. And when and in whom should we be initiating OAC? Is there any particular OAC that we would prefer to use? And then talks about antiplatelet drug combinations with OACs. A lot of our patients have ischemic heart disease, and certainly a significant proportion have gone on to undergo PCI or presented with an acute coronary syndrome. And then what happens if a patient has a residual ischemic stroke despite being on an OAC? And then, what should we do with bleeding risks? And particularly if it's high, what can we do? I'm just really going to talk about the first couple of aspects here, but these are certainly questions we should be asking ourselves whenever we see a patient with AF, and particularly if we're going to start somebody on an OAC. So just briefly, CHA2DS2-VASc score of more than 2, it's recommended. If it's 1, it should be considered. The CHA2DS2-VASc score is not the be-all and end-all of deciding who should be on an OAC. There are other parameters that it doesn't take into account, such as chronic kidney disease, ethnicity. We know that patients who have elevated BNP levels and troponin levels are at increased risk of having thromboembolic disease. CKD itself, we know with reducing GFR and proteinuria, that in itself is associated with increased risk. And I'm sure over the next few years or so, we are going to start seeing more and more cardiac biomarkers be incorporated to some of these risk tools, such as the troponin and BNP that I mentioned. But also we know that growth factor 15 and cystatin C and IL-6 can also give you an idea of what the residual stroke risk is. So though CHA2DS2-VASc is something we should be using, it's not the be-all and end-all, and really need to look at other parameters as well. And just 3 conditions that I think we probably don't pay too much attention to, that CHA2DS2-VASc doesn't really incorporate, and that's those who have trigger-induced AF. So those patients who have AF which has been aggravated or precipitated by a potentially reversible factor. And we've all seen it, patients who come in with sepsis, pneumonia, they develop AF, and these patients should really be considered for OAC if they are elevated thromboembolic risk, and that would be based on a CHA2DS2-VASc score. And we know that the patients with certain congenital heart disease, OAC is recommended in all those patients, and I've just given a brief list of diagnoses down there. And then also in the context of cancer, we know that cancer itself increases your risk of thromboembolic disease and stroke, and sometimes putting a patient on OAC can actually unmask cancer, and we certainly saw that when we started using DAPT in acute coronary syndrome. Some of these patients will end up having hematuria, they're going to get seen by the urologist, and they actually unmask the bladder cancer. So that's just a few additional slides. So are all OACs the same? So there are, the 4 major ones we have are edoxaban, rivaroxaban, dabigatran, and apixaban, and there are subtle differences between each of them, particularly in regards to mechanism of action. 3 of them are direct factor 10A inhibitors. One's a direct thrombin inhibitor. If we look at the actual trial sizes, they vary. They are all very large trials, the smallest one being 14,000. There are differences in dose frequency. A couple of them are twice a day, a couple of them are once a day. And then if we look at the actual patient characteristics, some have higher CHA2DS2-VASc score. They all use the CHA2DS2 score, not the CHA2DS2-VASc score. And also if we look at the time within therapeutic range, you see with the edoxaban, almost 70% of patients had warfarin within the therapeutic range between 2 and 0, whereas with the rivaroxaban study, it was 55%. So it's certainly a significant difference there. And also, if we look at those patients who are more likely to bleed, those with the Hasbled score of 3, which is what we use to identify patients at increased bleeding risk, not to identify those patients who should not be on it, but really to focus on what other aspects of patient care management we can do to try and reduce that bleeding risk even further. Half the patients in across the trials, it varied from 10% up to 60%. So they're basically the 4 different trials. So if we talk about the Engage AF TIMI 48, which was really the largest trial that was published, which is around 21,000 patients or so. And you can see at the bottom that it incorporated a large cohort of patients. 40% of patients were over the age of 75. As I've said already, about 50% were in the high bleeding risk. Almost all the patients were hypertensive, 94%. We see a significant proportion of patients were diabetic, 36%. Diabetes in AF has its own nuances in that they are more prone to bleeding. So the study really incorporated probably the vast degree of patients that you would see in your clinical practice. And what did the study show? Well, it showed that it significantly reduced your stroke and systemic embolization compared to warfarin. And again, remember, a significant proportion. This trial had the highest percentage of patients whose OAC control on warfarin was around 70%, where some of the other studies was much lower. There was no similar reduction in ischemic stroke, but there was a significant reduction in hemorrhagic stroke. So your systemic embolization and your risk of having and adverse bleed was certainly significantly lower with the once-a-day edoxaban preparation. If we look at the different subgroups, we can see that there certainly wasn't any signals suggesting that any subgroups, their medication wasn't effective. The edoxaban suggested was better even in patients who were taking aspirin use. If we go on to the next slide, you can see that the bleeding rates were significantly lower with edoxaban compared to warfarin. And that was in really the three major categories of bleeding that we're concerned about: intracranial, life-threatening, and fatal bleeding was significantly lower with edoxaban compared to warfarin. If we look at the major subpopulations with regards to bleeding, again, there almost all groups had better outcomes with the edoxaban. If we look at those groups who had high thromboembolic risk, so CHAD score of more than 3, again, edoxaban was certainly not worse than warfarin. Patients who were elderly, who are more prone to bleeding, edoxaban was better. Diabetic patients, we know that they do tend to have more bleeding issues, and edoxaban was better in that subgroup population as well. If we try and compare that with all of the other studies, and I said there are certain nuances between all the different DOACs. Some are once a day, some are twice a day. The two that really showed that they were better with regards to annualized bleeding rates were apixaban and edoxaban. Rivaroxaban, there was certainly an increase in GI bleeding, but if you try and put it all together, you can see that really the bleeding rates are much lower with the DOACs than they are with the conventional anticoagulant therapy that we had prior warfarin. And again, if we look at the GI bleeding, as I mentioned, the rivaroxaban was associated with a slight increase in GI bleeding. But the apixaban and edoxaban tended to swerve more towards the left than be in the center or towards the right. One of the major issues we have in really treating patients, and this is not isolated to atrial fibrillation, is medication adherence and medication compliance. And there was a meta-analysis published in 2020 which looked at this, and they showed that there was certainly a significant proportion of patients who were either given too much DOAC or too little DOAC, and too little DOAC was certainly associated with a significantly increased risk of stroke. So if we look at data from the Kuwaiti market, you can see that the prescriptions for the lower dose of apixaban is higher than the conventional dose of 5 milligrams twice a day. And certainly you have significant prescriptions for the lower dose of rivaroxaban and also the very low dose of dabigatran of 75 milligrams once a day. I mean, we don't even get to the 110, but we're certainly below 75. And that all of that has really been associated with a significant increase in bleeding, in ischemic events with similar bleeding rates. So you don't get the added benefit of reduction in bleeding, but you do get the adverse outcome of increase in systemic embolization. So with regards to patients who are at increased risk, certainly with regards to edoxaban, patients are identified by either having impaired renal function, so a creatinine clearance of between 30 and 50, low body weight, and their use of the P-glycoprotein inhibitor use. So particularly with regards to antiarrhythmic therapy, verapamil or dronabinol or quinidine or some of the other antifungal medications. So concomitant use of any of those medications, then the lower dose of 30 milligrams once a day was preferred. And this was certainly showed that there was still a significant reduction in risk, or not, there was similar reduction in risk of stroke, numerically lower in the edoxaban, but that didn't reach statistical significance. What about with regards to major bleeding in the cohort of patients who are at increased bleeding risk? And this did actually reach statistical significance with a 37% relative risk reduction with the edoxaban as opposed to warfarin. And then if we look at overall cardiovascular mortality compared with well-managed warfarin therapy, you can see the edoxaban was associated with similar all-cause mortality, but cardiovascular mortality was reduced in the edoxaban subgroup. I mentioned briefly that diabetes mellitus type 2 certainly has its own issues. AF is not only more frequent with type 2 diabetes than those without type 2 diabetes, but it's associated with an increased risk of bleeding. We have seen a significant increase in the prevalence of diabetes over the last decade or so in the Middle East. So this is certainly an ongoing issue. And in the TUMI 48 study, a third of the patients were diabetic. So again, we certainly have a significant proportion of patients in whom edoxaban was trialed in the diabetic patients. And you can see, if we compare it in all four DOACs that we have, the bigger trend showed significant reduction in stroke or systemic embolization, but as a group, DOACs fared better than warfarin for preventing strokes and systemic embolizations. And again, if we take this one step further and look at major bleeding, so we have reduction in stroke. Now we want to ensure that we don't have significant excessive bleeding. We see that edoxaban was the only DOAC that had reduction in major bleeding compared to the other three DOACs that are available to us. And as we know that as we get older, the risk of AF increases, and not only does the risk of AF increases, along with that, the risk of bleeding increases. So it's important that we try and utilize an anticoagulant that will not only reduce the risk of stroke, but will not increase the risk of major bleeding. So what about in the elderly population? We are seeing more and more patients with AF. So 40% of patients in the TUMI 48 study had were over the age of 75. And you can see that edoxaban compared to warfarin had a numerically lower stroke, systemic embolization. Importantly, it had a lower incidence of major bleeding and lower incidence of intracerebral hemorrhaging. So in the elderly population, we have a reduction in stroke. So we want to see on the graph on the left, we want to see everything really to the left-hand side, and on the graph on the right, we want to see everything on the left-hand side. So we're really looking for medications that will reduce your risk of stroke, but also reduce your risk in major bleeding. And there were only two drugs that really benefited, the edoxaban and the apixaban. But again, there are subtle differences. We've already talked about medication non-adherence or being underdosed, and certainly having a once-a-day preparation is far superior to medication adherence and having a twice-a-day preparation. So what about efficacy and safety in patients with coronary artery disease? Again, it showed that there was a reduction in ischemic events with edoxaban, and also there was no association of increased bleeding. In fact, there was less bleeding taking edoxaban plus aspirin compared to warfarin plus aspirin. And this is really just showing the reduction in stroke and systemic embolization of all the four major DOACs, reduction in major bleeding and myocardial infarction in patients with coronary artery disease. And edoxaban was really the only one in the subgroup analysis that showed a reduction in myocardial infarction, and also reduction in stroke and systemic embolization in the CAD population. So adherence to therapy, it doesn't matter if you take a medication once a day or twice a day. Medication non-adherence is associated with adverse outcomes. So edoxaban was really, taking edoxaban, you're more likely to take it, more likely to be properly protected. Certainly comparing it with the other twice-a-day preparations and oral vitamin K antagonists, the likelihood of running into adverse outcomes with edoxaban compared to the others with regards to medication adherence was certainly significantly better. So just really basically a summary of those patients who should take, it's a 60 milligram once a day, and those patients who have high bleeding risk, renal impairment, low body weight, or P-glycoprotein inhibitors, the once a day 30 milligram preparation would be recommended. So I've tried to go through that fairly quickly. I know it's late at night, but if anyone has any questions, I'm certainly happy to answer them.
Thank you so much, Zafar, for this overview. We're right at 9 o'clock I would like to thank everyone, especially the presenters, Jack, Mario, Saif, Fridun, Ali, and Zafar for your time. Really means a lot to take away from your busy calendars and to dedicate this to education. So just to be respectful of everyone's time, this will bring this session to an end. I hope it was informative to everyone, and thank you so much, and good evening to everyone.